Good evening. Yeah, I'm Dr. Shibam. Thank you very much. Thanks for welcoming me in this platform. And I hope my sound is better.
Yes, it's perfect.
No.
Thanks.
Okay, no, thank you. So yeah, today we'll be talking about one of the important topics, neonatal resuscitation. As we had through your introduction, saying breast asphyxia is one of the top 3 leading cause of death of neonates. And we know the breast asphyxia come with lots of complications. We have a CP, learning disability. Lots is one of the devastating problem to deal with, even for the families, even for the health resources. It demand a lot. So that can be prevented by good resuscitation, that's why we are talking about this, so that we make sure that everyone is aware about how to do a basic neonatal resuscitation to prevent lots of complication, and to also prevent to be sued. The government is crippled by litigations. Is paying millions of rent, mainly because one of the main causes is because of the breast asphyxia, which we have failed to resuscitate, or was a delay in managing that. So I'll be talking about neonatal resuscitation. We go more on the basic. I won't dwell more on the physiology side. We just want something that you can be able to take home as a message, so that you learn, because if you go detail in physiology, you end up losing the most important things that you need to remember. So yeah, that's how we're gonna start our talk for tonight. So I was asked to switch off my video. I'll just save it off so that don't distract other people. Okay. As we start, with the question, why do we have to learn to do neonatal resuscitation? If neonatal resuscitation is important, and then when this is implemented systematically by personnel using standard guidelines and some competency-based training, has a potential to prevent about 30% of intrapartum related neonatal death per year, every year. You can see how much this helps. And also, it may also prevent about 5–10% of death due to complication of preterm death. So you can tell, if we don't know how to do neonatal resuscitation, we are going to lose much more babies who were supposed to have survived. So when we talk about neonatal resuscitations, it's important for people to know about the reason why most of the neonates were required to resuscitation is because they fail to transition from fetal circulation to the normal extrauterine life. Because during fetal circulation, these babies didn't require their lung for breathing, for gaseous exchange. So the placenta was doing that job that is done by the lungs. So most people who are involved with children, they should be aware of this, that all the bloods or food, when nutrients will come from the placenta all the way, bypass the liver through the ductus arteriosa, enter in inferior vena cava to the heart on the right side of the heart. And you remember when you get here, because the pulmonary artery have too much high pressure, so less blood will go there. So most blood will bypass there, go to the right through that what we call foramen ovale, and then to the left side of the heart, then go out to the aorta, and then go to the rest of the body. So there's also some duct here we call ductus arteriosa, which is the one that we shed blood from the pulmonary system to the aorta. As we said, that the lungs are not really active. The lung at this stage, they are really full of water. But there is a transition as the lung matured around the 28 weeks gestational age, the lung, they start getting some surfactants has to develop, and then the process start, which will end during the time when the baby is born. When the baby have that, during the labor contraction, some of the water get pushed out. And when the baby is born, when it starts breathing, the pressures change. There's now high pressure on the arterial side, the less pressure in the pulmonary. So the more blood flows to the lungs, replacing the water that was filling the lung. So that's when that's when they start breathing normal on their own without the need of a placenta. So some of the babies who will really struggle with that transition, those are the babies who may require a resuscitation. So that's why we'll be doing resuscitation to know how to assist those who fail to transition on their own, how do you assist them? So those are ones that will assist them using a resuscitation. This is just basically what I was just talking about. That there is a decrease in pulmonary vascular resistance and an increased pulmonary blood flow. That's after the baby is born, and this which will cause increased arterial oxygen tension after the baby starts breathing. And that's the cases change. Right, the placenta stops and the lung will take over that function. That's what I just spoke. And how do we know that we have transitioned successfully? So when the transition successfully, that's when the alveolar fluid clearance. Now the alveolar that was filled with fluid now get filled with air, and the lung expand. There's a lung expansion. And the secretory changes with increase in pulmonary perfusion and systemic pressure. And that causes the closure of the right to left shunt of the fetal circulation. So if this happens, we know those are the ones who have transitioned successfully. There are those who are likely to breathe spontaneously, normally after birth if they transition successfully. So those who don't, they may have a problem somewhere, and that's the one that will be able to assist. And this slide that I just put up now is just trying to show very few newborns will require any resuscitation. You must know that about 85% of those babies will breathe spontaneously within 10 to 30 seconds after birth. So they won't need anything. And how many? Only about 10% will need some intervention, which intervention will be about 5 to 10% of those will just be simple, stimulate them, dry them, and then they'll start breathing, and that's all that will require. And about 3 to 6%, they will just require basic resuscitation, which will be bag and mask ventilation. So most of the time we'll end up here. The very rare case where we have to do advanced resuscitation, where you require to do the CPR, require the use of adrenaline, require those chest compressions. So there are very few of those. It's less than 1% of those who require intensive resuscitation of measures after birth. So you can see there are very few that we need to assist. And those few, we must be ready on how to assist them, because when they come, if you don't know how to do it, it will make you sweat because you'll be frustrated. Yeah, blood pressure will be too high, the mother will be too high. So at the end, all of you guys will end up becoming like a sick because you won't be able to assist this baby. So we need somebody who will know what to do, who will be calm and able to assist and control the situation. So to do a successful neonatal resuscitation, there are factors that you should put into consideration. Firstly, we need to anticipate. Anticipation what? Anticipating the condition or the babies who may require resuscitation even before they are born. so that you can have a proper preparation. So you need adequate preparation, and you need some accurate evaluation to see if this baby was born, does the baby require any assistance or not? If require, you must follow some algorithms that are available, some guidelines that are available in our institutions. So which must make sure that those algorithms are updated now and then, because some things change as things better, that thing comes, there's some update changes that are meant to update. And you start supporting immediately. So when talking about anticipation, there are some conditions that you must anticipate that there may be a need to resuscitate, especially in the case of intrauterine growth restriction, so the prematurity, and even the post-date, the multiple pregnancy like twins or triplets or whatever. So you might anticipate there may be some need for resuscitation. In the presence of oligohydramnion or polyhydramnion, there may also be a need for resuscitation. Looking at the maternal side, the mothers who have some infections with gestational diabetes, with preeclampsia, those who have obese, high BMI. So, and those one we may anticipate resuscitation, and those prem who mother didn't get the antenatal steroids. And in the presence of abnormal CTG, we showing the fetal distress, you might also anticipate the need for resuscitate. The presence of meconium stained amniotic fluids, you must also anticipate to resuscitate. In the breech deliveries and in the presence of antepartum hemorrhages or C-section before the 9 weeks, that's the same as like C-section before delivery, those can get some TTN. So, and those who are being delivered under anesthesia. If you have this kind of condition, you must anticipate in this and may require resuscitation, so they can prepare everything that you may need to resuscitate. Because you don't want to start looking for things when you are already in trouble, because you don't have enough time to do that. So talking about the adequate preparation, so as you prepare for a resuscitation, you have anticipated that there may be a need to resuscitate. You have to, the place that resuscitate should be warm place, because you can't resuscitate in the cold environment, because hypothermia will make your resuscitation to be unsuccessful, as because it can worsen the complication, the problem that the baby can complicate further. So if you have a radiator warmer, it must be turned on and it's heated. Make sure it's warm, so that when the baby comes, the environment is proper. And make sure that the oxygen source is open and is working, and you have tested it. Check your suctions, make it get tested, and make sure it's functioning normally. Because when the baby comes, your suction is not working. By the time you look, organize things, you're already losing more time, and the baby is already dying, because there's something called the golden minute, which we'll talk about. And check your laryngoscope is functioning and is bright enough, so that when you were to go to use laryngoscope, you can be able to see and intubate without difficulty. And testing of a resuscitation bag and mask, and then check even all the pressures are fine, everything's working well. So all this should be done for every delivery that you are going. If you had a delivery before you are going for the second one, you may be checking the first one, the second one I don't check. Something may have changed, something may be removed from your emergency trolley. So you have to make sure you check during every delivery, you check everything, all your equipments are available and everything is working well, so that when you need to resuscitate, you have everything in order. Part of resuscitation is also checking all your equipment. those who are using the arm bag, make sure it's working, you test it, that is working, radiator warmer is switched on, laryngoscope, we check it's working well. For those who have the CPAP, which not CPAP, the Neopath, which is the best one that can help you to you can bag with this is the better one that can use in case you have it. It may not be available everywhere, but when you have it, it's good because you can easily control the pressures and the amount of oxygen you are giving. It will work better for those who have. If those who don't have, it's possible, better to have one. We spoke about how testing, must also learn how to test the amp bag to see it's working for those who are still using the amp bag. Checking all the equipment. You can check it in another way to know what we need. Suction, we spoke about we need the suction. We check all the stethoscope is fine. You need a pulse oximeter, the gloves, check the suction, the different size, all the equipment that you need for resuscitation. I just put them there. I won't have to repeat to call all of them, but just make sure you will have them closer. And the drugs that you are likely to need during resuscitation, mainly adrenaline, and naloxone may be needed in case where there was the use of an opioid may be necessary, and some normal saline, neolite, and the drip sets and the stuff. So in this one, I'm just showing you so that you make sure you have checked all your equipment. It should be some way of having a checklist. And someone must tick almost every time that all these things are available on your resuscitation trolley. Because when you need it, there'll be no time. So I'll start talking about going to a resuscitation by putting the slides. I think most of you guys may have been seeing this. Some may have been trained on helping baby breathe course that is available in the country. And this was designed for everyone who work with the babies, starting from the midwives, the obstetrician, all the doctors working obstetrics, all interns should know, every doctor. In fact, everyone who comes close to newborn should know how to help the baby breathe. Specifically the basic resuscitation, the advanced resuscitation to be continued by the doctors and those who are trained to do the advanced resuscitation. So I just put this slide just as a reminder. So our talk, part of it will be starting from here, because I remember when it started, I spoke about the golden minute, which these slides also show. So we're going to take you through what happened what should happen in that first minute. So this one just showing what you should do in that first minute when the baby is born. So when the baby is born, as we mentioned, that 85% of them, they won't require any resuscitations. So when they are born, you must just dry them thoroughly. And if they are crying, you just keep them warm. You can put them on the mother's tummy as the gynae are busy or midwife are busy finishing up with delivering the placenta or suturing all whatever they've done. So you don't need to do any resuscitation on that. So you can see those things can be done within a minute. All this can be done, the cord can be cut. And then for the case where the baby is not crying a little after birth, you dry the baby, you stimulate, if it's not crying, you must keep warm, you clear the airways, you stimulate. If it's after stimulation you breathe, you just and breathing well, you can still keep the baby warm. You can put on the mother's tummy if the baby is fine, then keep the baby warm. But in case it's not breathing, after you have stimulated, Now you have to do that way to resuscitate. Now we have to ventilate. How do we ventilate? Now you start picking, giving the oxygen. That's when we start. And that process should start within a minute. So that's when they talk about golden minutes. The going down will take you through. So I'll be going, this one is what derived from the algorithm that I'll be talking about. So which they were coming from American Heart Association, American Academy of Pediatricians, and ILCO guidelines and the European Resuscitation Council. So these were derived from those. So I'll be using this one mainly to take you on a stepwise on how to do a resuscitation. We are just gonna take you back because I think this is one of the important slides, the golden minute. It's very important. That's why I'll repeat it. So we already spoken about preparation of checking equipment, and the baby, when the baby is born, there are questions that you need to ask yourself after the baby is born. Is this a term baby? How is the tone? Is the tone good? Is the baby breathing or is crying? If that baby is crying, and the answer is yes for all those questions, so then the infant can stay with the mother for routine care, warm, maintain normal temperature, just maintain the position, the airway. You may clear the secretion if needed. It's not, it doesn't have to be done in every baby. Some of them, they don't need any suction, and they dry the baby. And just keep checking, because some they may be well for a while, but they change. So you keep evaluating, checking the baby health is still okay. So if this question that we ask, some of them are not correct, that the baby is not breathing, the answer is no, it's not breathing. So you still have to maintain the baby warm, keep the temperature normal. For thin airway, you clear secretion, you try and stimulate. After your stimulation, and then you find that the baby is just gasping or just not breathing at all. And with the bradycardia, the heart rate, you find that it's less than 100. So if you are check that, then it means now you need to apply the positive pressure ventilation. We need to bag the baby. You can use the amber bag, or those who have Neonatal, they can use a Neonatal just to give oxygen within that first minute. So that's what will happen in the first minute. That's what we call a golden minute, which will be, if it's done correctly, we may not need to go further. So I hope we understand what we expected to do in the first minute. You dry, you warm, keep warm, you dry, clear airway, stimulate. If there need be that the heart rate is low, this apnea, this gasping or labor breathing, the heart rate is low, that's when now you know we need to proceed with the positive pressure ventilation. Now you must pack the baby. Within first minute. So this, you can do this if you are prepared your stuff, but if not prepared, you won't manage to keep it with this time. So when we pass the first minute, that golden minute, and this baby is still not breathing okay, you have the heart rate below 100 and is having apnea, or it's not breathing. What next step to do? So we have mentioned, I'll keep repeating some of the things so that by the time I finish, you can remember them, because some of the things are very important. It's more of take-home message that you should always remember. We spoke about that you need to do a thorough evaluation of the baby after it's born. Repeat assessment of neonatal clinical status. Is the infant full term? Is it breathing? Is crying? Does the infant have a good muscle tone? If the answer is yes, no resuscitation is needed, just routine neonatal care. If the answer from the above question is no, then now there's a need to resuscitate. So we'll be following this in case for those who there's a need to resuscitate. Start from ventilation, we'll talk about, we'll go down compression, and then if there's a need for medication, we'll follow this. So we mentioned if now they require the heart rate is low, or not breathing or just gasping, we said we must apply back mask ventilation. I'll take you through a little bit on the back mask ventilation, because you may do a back ventilation, but if we are not done correctly, you may not achieve the goal that you want. So as we go there, just gonna give you through a quick talk about that back mask ventilation so that we do it correctly. So this one is only needed if there's no improvement with the heart rate. And the EUS you bag should be delivered at the rate about 40 to 60 breaths per minute. These are how fast you should bag. And we try to maintain heart rate at least above more than 100 per minute in a minute. So to apply the positive pressure ventilation, you can use back mask ventilation. Some may need to be intubated to be able to do that. You may need a laryngeal mask away if necessary, but not everyone will require those. And as you are going to do that, back mask ventilation, the one thing that you must also remember is to have the baby positioned correctly. It must be put on the flat surface, and you must position the neck correctly, because if you put that baby with the neck in a flexion, you block the air. Even though you are begging, they won't be able to get the air through to the baby's lung. So it won't be successful one way. So the baby must be positioned correctly. Correct position, in a neutral position, not flexed, also not hyperextended. So just remember that as you are resuscitating, that you put them in you correct them, you put them in the right position. And also, as we are continuing to talk about suctioning, those who have done helping they breathe, they may remember neonatally. So this is the door that we use during the training. So the suctioning is not everyone who requires suctioning. Some they don't need. And in the event where there's meconium, and the baby is not breathing, just remember that you must suction the mouth first before you suction the nose, because you suction the nose, you are stimulating the baby will start gasping or breathing and swallow in all the meconium that is in the mouth, in the oral cavity, may end up going to the lung and cause the aspiration. So just remember that. But for those who are already crying, it's really there's no need for that, because if there's something in the mouth, it's already down to the lung. So part of evaluation, you have to assess this spontaneously. You check the baby breathing, and then check the heart rate. And if you have the pulse oximeter, you can really connect pulse oximeter surface, you assess the oxygenation. You have done the initial section we mentioned about the drying up, the stimulating session, keeping the baby warm. Those are initial stimulation, and the positive pressure ventilation. That's what we just spoke about, the back mask ventilation or the use of CPAP. So you always, as you do this, you always have to assess all these things so that you ask yourself if there's a need to continue resuscitation or not. Back to our algorithm. So if we are now, you are begging and there's still not enough oxygenation, you may intubate so that we can be able to deliver adequate oxygen into the baby's lung. So that may need to go that in if there's a need. But you don't start there, you start by begging, because most of them by doing the bag mass ventilation may be sufficient. So ventilating with a bag mask, and those who have done basic resuscitation, you must just, they usually teach you on how to hold the mask. That still apply, because some just putting the mask in the mouth is not gonna, it won't work if you're not put correctly. You just have to know this easy clamp technique. It also applies to the neonate. So you must just learn how to do this. So we already spoke more about it, so I won't waste much time on this slide. So now, after you have been resuscitating about a minute with a bag mask ventilation, and there's no improvement, still maybe not breathing, the heart rate is still low. Now is the time to proceed to the chest compression. So we'll talk a little bit about the chest compression. So when there's a need for chest compression, the chest compression in this case will be done in a coordination of the positive pressure ventilation. So it works well. So doing resuscitation, you can't do resuscitation alone. You need another personnel to assist you, because you need one to be attending to the airway and another one to be able to do the back mask, the chest compression. So there are two techniques that we use in the neonates to do a chest compression. So the one can use a two fingers technique. So that's the one you can use two finger techniques, just showing you a landmark where you can put your fingers. So you put at least 2/3, 1/3 compression. So you don't have to go deeper. This is a neonate, a small baby. The chest is not as hard like adults. So the two fingers is sufficient to do a compression on this one. You can use that, or you can use the two hands where you put all your hands around the baby, your thumb there there by the sternum. So these are the two techniques that we use to do a chest compression in the neonates. And as mentioned, chest compression to a depth 1/3 of AP diameter of the chest. And as we do, there should be some coordination. As mentioned, you need somebody to coordinate with the colleague. So how we do this in the CPR in the neonates, one will be attending the airway begging. So more likely it will be one of the health professionals. If it's a doctor and the midwife, who will prevent, the doctor should be mainly the one on the airway, and the midwife or another assistant to be on doing the chest compression. The role can be swapped at that time. So as we beg, the one who's a leader, there should be a team leader in the group who must count, because you can't just do something quiet, because you must know that we are all doing well. So as we do chest compression, you must count if you are compressing 1, 2, 3, 1 back, 1, 2, 3 back, 1, 2, 3 back. That's the rate in the. If possible, one of our teacher used to do in the table, just counting, so back. So that if that's possible, you can still do that. It works. At least you know you are doing it in the right rate, which is good enough to make your session successful. So you just need to practice that. You do your chest compression, 1, 2, 3 compression, and you 1 back. 1, 2, 3 compression, you back. 1, 2, 3 compression, you back. So that's how the neonatal resuscitation is done. It's not the same as adult when you do all the compression for about 16 and then 15, and then you come and give oxygen. For this one is different. 1, 2, 3, and you 1, 2, 3 compression, and you give an oxygen. So this, you can manage to do this by doing the training. So this helping they breathe. They teach you more on this part, because this is very important. Most of the resuscitation may end up, you may not need to go further. I hope we are still together.
Yes, we are with you, Doc. Thank you.
Okay. Okay. Thank you. So this when we talk about coordination chest compression with the positive pressure ventilation. So there are those even after that chest compression and the positive pressure ventilation that still you fail to get the heart rate up. They still remain with the low heart rate, or they're still not breathing, or just still they just a gasp. Now, in the event of that, that's when you may need to go down to the need for drugs. If you remember the slide that I put before, is very few, in fact about 0.01 who require drugs. Through my experience, I can't remember this year if we have used any adrenaline in the neonate during the resuscitation. Most of them we just ended on the back mask ventilation. There was not even a need for a chest compression. There are very few circumstances where you may end up there. But it's important to know in the case where you need what you need to do. So you only need medication when the heart rate will remain less than 60 despite adequate ventilation and adequate chest compression. That's when we need use of epinephrine, or some may even need some fluid balance like normal saline. So the drugs that we usually use for resuscitation that to assist the heart rate, we use epinephrine. We may know it as adrenaline. We use it at a dose of for the neonates, you have to dilute it. You take 1 ampoule, which is 1 ml, you mix with the 9 ml of, can use of sterile water, or can use of normal saline. You mix that, and then you have 10 ml. So that it make it 1:10,000. So you can even calculate using the mils. Using that means 0.1 ml to 0.3 ml per kilogram. That's the amount you give, so you know you're giving the right dose. So, but in the event where you do not have a drip, or you don't have any line, that can still be given using the ET tube. But in the ET tube, it will require high dose, which you can see in this one is about 0.3 to 0.1 ml per kilogram. So it's a bit higher than the one if you're giving IV. So this is a drug that we use. So other drugs that we use it, rarely use them. So, but what you need to know is about the use of adrenaline. These are the dose that we use to administer that. And these drugs should be on your emergency trolley, whether the resuscitation or not, should always be there as you go. As part of our preparation is to check that these drugs are there in your trolley at all times before even the delivery starts. And after delivery, just have to know there are the saturation that we accepted just after delivery, immediately after birth. So at birth, in first minutes, saturation of 60 to 70% is accepted just a minute after birth. That saturation, as the baby is breathing, getting the resource exchange is increasing, the saturation it also increase. We expect every neonate by the 10 minutes, the saturation is about 85 to 90%, still accepted. It doesn't have to be 100%, it's accepted. So then by after the day, 24 hours, these are the normal accepted saturation. So for preterm, more than 90 is accepted even after 24 hours. So we don't want to see 100% in the neonates in the preterm baby, because most people will be so happy by seeing monitor 100%, but that 100% will be doing more damage than helping, because may end up having the child with a blind child caused by our oxygen. So we always have to control the oxygen that we deliver to the preterm babies. If it's too high, you have to reduce the oxygen that we are supplying. So I thought it won't be good that we end this talk without talking a little bit about this slide, because it's very important maybe to help us to start acting rapidly to prevent losing these babies during resuscitation. So here I'm just showing, this was one of the study that were done to the animals many years ago. They were just trying to check what's happening during the apnea, when the baby is not breathing, or during hypoxia. So what happened during hypoxia? The baby before born can gasp in the utero, can do some gasp in the utero when the presence of hypoxia. So that gasp, that's what they call it. And then if whatever causing the hypoxia is not corrected at that, and then they may stop to breathe, and then that's what we call it, the primary apnea. The primary apnea. And at this stage, during the primary apnea, if you check, the heart rate is still maintained, and the blood pressure they are also still acceptable at that time. So which means if this get corrected, the heart rate is likely to go up. But in the presence where that hypoxia continues, and then you get another gasp, and you get as they're getting more gasp and more apnea, now you see the heart rate will start dropping. Also, along with the blood pressure will start going down. So, which that process is, it can take about 10 minutes. So if nothing is done between that beginning of first primary apnea and around 10 minutes, you get another gasp and get another prolonged apnea, which now it's called secondary apnea, which if it's not corrected, now that baby may die. The heart rate is dropped here. If there was no resuscitation done, that heart rate will drop until that baby, the heart stop beating. The same with the blood pressure, it will drop until that it stop beating. But if the resuscitation, what you see here, they're just showing here that when in here the resuscitation was initiated, that's why we see the heart rate went up, the blood pressure went up. But if nothing is done, they will die. And at this stage, if it's still not breathing, you can see that's the moment where the brain starts to suffer. Because at this stage, I must take you back, if you check up there, we talk about the pH at first was 7.3, but around 10 minutes, it was already 6.8. That was already severe acidosis. look at the PCO2, we started, PCO2 was 45, but around the same 10 minutes, it was at PCO2 has 150. And because there was a hypoxia, there was no oxygenation, the metabolism was also disturbed. There are also some lactic acidosis taking place. So here, they already developed the mixed respiratory and metabolic acidosis, which their acidosis also have much effect onto in the developing brain. So if nothing is done here, that's where we'll start having the problem with the brain. They start having the problem of asphyxia, the brain damage, and the more time we take, the more the brain get damage. So if we were to assist and prevent the secondary apnea, is to have done the proper resuscitation within the first 5 minutes. We should save that baby from going to the complication of burst asphyxia. So most things must be done very quick. And the first 5 minutes for me is important after adhering to that golden minute. So this one, I know it can be a bit complicated for other people, but it's just showing the damage that may happen if the problem is not corrected. So as we do, we resuscitate, you must also remember you cannot resuscitate forever. There is a point if you are not successful with your resuscitation, and if you are not successful with resuscitation, or that resuscitating, the heart rate is not coming up or it's not improving, there's no breathing, there is a point where we should say now is enough. Then you can stop resuscitating, because continuous resuscitation is not gonna bear any good results. So following general guidelines, this guideline may assist. If the baby has no heart rate after 10 minutes of ventilation, then you can stop, because it means that baby, you can consider that baby as dead. If there's no heart rate after 10 minutes of waiting, you may stop resuscitating. Or also you can stop resuscitating in the case when the babies are those who don't really have chances to survive. So like in this extreme prematurity, like you have 500 grams, 400 grams. So those one, there is no need to resuscitate them. Those who come with some congenital abnormalities that come in encephaly, the trisomy 13, trisomy 18, those one you can stop. We don't even need to start to resuscitate them. So also, if there's no breathing effort whatsoever after 20 minutes, it's not breathing after 20, there's no breathing effort after 20 minutes, you can stop. Or if it's only gasping respiration after 30 minutes, then you can stop resuscitation. So with this one, even though they can come and start breathing later, you know that brain is already finished. So you are likely to have a severe cerebral handicap. You're going to have a severe CP. So these are the decisions which are very difficult, because sometimes you are doing things, the mother or the parents, somebody is there watching you, or being expecting to do some miracle to raise the baby. Sometimes because we are also human beings, our emotions also tells us, no, maybe if I continue, something may change. So if you understand what we just saw, we know if 20 minutes there's nothing, you know that brain is already having a problem, because this baby gonna just have a severe asphyxia or with the serious complications. I used to have one of my consultants when I was still under training. If I find you are still begging a child for very long, you ask you, are you going to do a brain transplant to that baby? Because you know you can't win, but your heart is saying, no, maybe I can go and 30 minutes, go 1 hour, resuscitating, and you know there's nothing coming. Just doing that just to satisfy your conscience. But we know the reason we're saying that because it's not gonna really make any change. When I continue for 1 hour, 2 hours, it's not gonna bring that baby back. So I'm putting this so that you must know when to stop resuscitation in the case where you were not successful. This is a situation where you can stop resuscitation. And for those who have resuscitated successfully, you must keep them warm, keep a normal temperature for them, keep well oxygenated, and give fluids and maintain a good glucose and maintain good perfusion. For those who have a bit of asphyxia or with seizures, you may treat seizures, and then just monitoring the organ function. So that's the basic principle that we do for those who have survived our resuscitation, or those that we resuscitated and they successfully. And for those who, after resuscitation, they are well, you may place them on the mother skin-to-skin contact, keep them warm, monitor them every 15 minutes. They can start breastfeeding soon after, as soon as possible. This for those who are resuscitated and they look well, they're breathing okay, they don't need any support. So there's no need to separate those from their mothers. So this generally the resuscitation, I'm just gonna check you quickly, just in summary of all what we just spoken about. That steps of resuscitation in summary. So first, you just keep the baby warm, place under a radiator warmer, open the airways. Open the airway, just must not position the head correctly, it never to expand and then never to flex. And you can suction the clear airway, a mouth and the nose. If he's still not breathing after that initial steps, then now you must ventilate. That's when you may start your back mask ventilation, or you can use of Neopath. If he start breathing and is crying, then you can stop ventilation. Then you're done well done. So that's the intent. Then in case where it does not breathe well, then you can proceed with all the steps of chest compressions, that step, and if that is still required necessary, you can go up to giving the drugs. So this is what we need to do in summary. So this one last slide, the message that I would like to send to everyone is that you must know that most infants will transfer from intrauterine to extrauterine life without any need of any help on their own. Is only 10% will need some form of intervention, and 1% will need extensive resuscitation. That's where we need the chest compression, and they may need to give some drugs less than 1%. And always must anticipate the need for resuscitation, looking at the risk factors that the mother have, looking at the gestational age, and looking if there was CTG, and check all the risk factors, and then that might anticipate the need for resuscitation. And then you must prepare adequately the neonatal resuscitation. And then there should be somebody who's okay to check resuscitation thoroughly every day to make sure that everything is there. And for those who are part of the delivery, they must check this equipment during every delivery to make sure that everything is there. And you must also evaluate newborn as per guidelines. You can use the American Heart Association, American Academic Pediatric Guidelines. Those algorithms that I was showing, they were derived from here. So learn how to use them. And also, those who are not trained in neonatal resuscitation, we recommend that they get trained so they know how to do this. the training take about 5 to 8 hours to do, just helping baby breathe resuscitation. So here it's just a summarizing on what to do, but the formal training, it will take about 5 to 8 hours for the basic neonatal resuscitation. So I think in summary, this is what I wanted to talk about neonatal resuscitation. So I hope people will have learned something. I know something may not be all possible. We're trying to show on how to use some of the equipments and stuff correctly. So yeah, that's what I have for you tonight. So I'll go back to Dr. Lisifo.
Yes. Oh, thank you very much, Dr. Shibamba. I think that was quite empowering. You know, even for me, I haven't worked in the pediatric section in a while, but I'm really, revived. And I think it was quite a systematic, approach. And I think those who have attended really appreciate this session. As you can see, we have in excess of 600 people who have attended. By virtue of this topic, it means it's a very important topic, because also if the research is not successful, we as health workers are left, with a lot of guilt and other things. So we really appreciate the preparation that went into this, but also the way you have taken time to take us through. There's a lot of questions, but I'm just going to cluster some of these questions and then maybe take hands, and then maybe we go back. There was a lot of questions about the when to check, what is the role of glucose in that algorithm, and when exactly should we be checking for glucose. And I think on the assessment side, it was the issue of your glucose levels. When exactly should we be looking at that? But also the issue of the saturation monitor, when on the assessment side, the initial assessment, the algorithm doesn't mention much. It might be because of in the rural settings, some of these machines are not there, or they are not well calibrated or something. Can you comment on that, Doc? Thanks.
Okay. Yeah, thank you very much. So yeah, I'll start with the issue of the saturation monitor.
Yes.
Yeah, we work in the different area, and I'm aware most of the labor ward may not be having that saturation monitor there for you to use immediately. But you don't need to wait for delay resuscitation while trying to get to connect saturation monitor. If you shouldn't, you need to have maybe assistants who will be doing that while the actual resuscitation is going on. Because I know it's important, but it's not something that you should take precedence against all the steps that we say. The main thing is to make sure you are doing the back mask ventilation, and that one will do as we stabilize the child, we'll check the glucose and we'll correct if the glucose is low. But it's not like we have to stop resuscitation and go for morning, give a glucose. And in terms of, we think we go with the saturation. If you are able to connect it quickly without disturbing the resuscitation process, it will be good, at least to help you to see if you are having the sites are going up, because also going to assist you to know your heart rate is high. But if you are in the remote area, what you should use to gauge if your heart rate is high, that's the training that is what we train the people who are doing healthy breathe. You can feel the pulse on the umbilical cord, on the baby's cord. You can, that's where you can feel if that the rate is fast enough. You can judge if this will be more than 100 or less than 100 is low, because as part of the training of the HBB, they teach you, if whoever's listening to the heart rate, you can tell those other guys who are there how fast. You can even tap down. So what? This how the heart rate is of that. You know this heart rate is fast. But if you are there, you're just saying
slow.
We know you don't have to be counting how many heartbeats per minute. You can tell that heart rate is very slow. But if you have all those things to communicate to connect, yes, it's okay. But I know in South Africa, most people they remotely with them may not really have that resuscitation monitor in front of them.
Yeah. No, okay. Thanks, Doc. So just for you to take a break, you spoke about the implications of poor resuscitation or our failure to call for help. There's Dr. Mbilaelo Chamiswe. I'd like her to comment because she's a pediatrician as well, but she's got also further studies in neurodevelopment. So let's maybe get some comments around the implications of not responding effectively on time and what are some of those implications. Dr. Mbilaelo, are you able to unmute?
Yeah, I think she's also one of those who is to do part of training of neonatal resuscitation. She should train, so she's still much involved. I think she's a very right person to answer most of these questions.
Okay, no, it's fine. I'm sure she will help you. You seem to have a lot of questions. Yes, Doc?
Hi, good evening, everyone. Thank you so much, Dr. Mawela, and thank you, Dr. Shibambu. This is quite an interesting topic, and I really wish colleagues we can take neonatal resuscitation seriously. In our neurodevelopment clinics, and even in the community, we see a lot of patients that have cerebral palsy. Not to say that cerebral palsy is because of only birth asphyxia, but we have a lot of preventable cerebral palsy. One cerebral palsy patient is enough. So I think we need to also go back to intrauterine resuscitation. We need to see the indication of poor progress if we're monitoring our babies or our mothers accordingly and we respond appropriately. Dr. Shibambu talked about primary and secondary apnea. I think we need to prevent as early as possible any form of apnea. You will see that the child is the CTG is starting to have decreased variability or bradycardia, and you take long to act on it. I understand some of the things are just beyond our control in terms of management or theater times, but we really have to take into consideration the consequences of apnea. So in terms of the cases that we see in neurodevelopment clinic, it's quite heartbreaking because families are forced to pull out of work to take off this child that we could have prevented. And Patrick also talked about when to stop. Sometimes when you are doing a lot of resuscitation or prolonged resuscitation, you are actually doing more harm than good. So we need to know when to stop. The 10 minute, if the patient is not breathing, you really need to consider stopping resuscitation. Or if you have been giving adrenaline after 20 minutes or all those 3 cycles, the resuscitation, adrenaline cycles, the 3 of them, and still there's no spontaneous breathing on heart rate. The more you continue to resuscitate, the more you're doing harm to the patient and also to the family. And we must also remember the burden of cerebral palsy or any child with developmental problems into our economy. It's quite bad. So let's go back to the basics. Let's take up the pathogram. Let's advocate for early cesarean section if we need to come out. And take serious the CTG tracing, those who have pathograms, and also the TOCO, what do they call it, that funnel thing. I don't, it's long since I've been in labor ward, but
Sure.
But
Dr. Magagula is also there's an obstetrician also here. I think in the follow-up session, we need to have a panel, anesthetist, obstetrician, the pediatrician, and yourself, just looking at some of the issues that you have raised. It seems like it's a very systematic, it requires a systems approach.
Yeah,
in terms of how we deal with it. Yeah,
it is. Thank you so much. Thank you, Dr. Mawela and Patrick. Thank you.
No. Thank you. Yeah, maybe she wanted to say CTG, maybe. I see Judith is trying to help you there, Doc, but it's okay.
Yeah.
No, it's fine. So Dr. Shibam, the issue of suctioning, there was a lot of questions about suctioning.
Yeah, I've seen some of the questions.
Someone is talking about endotracheal aspiration in babies suffering from meconium, and some people are just suctioning, even if there's nothing, even if the baby is screaming. What's your advice on that? Thanks.
Yes. So in the case of meconium aspiration, so the practice is the routine suctioning is also not important for all of them. So if baby is born and they is screaming, there's no need to suction, because if it was the issue baby to aspirate, whatever was in the mouth already deep down to the lungs. Where the suctioning is important, in the case where the baby comes, is not crying, but in that case, it also gives you time. Then you can intubate under direct laryngoscope and suction even before you stimulate the baby, and then you suction and then you stimulate. That's when the suctioning is important. But those who are crying, there's no need. For those who are not crying, yes, suction first, and then you stimulate. And even the suction, when you suction, first clear the mouth before the nose, because if you go start into the nose, it's part of stimulation, and you may end up having a gasp and then take everything that's in the mouth, swallow them back into the lung. Into the lungs, yeah. So that's what. I thought I should also ask there was also a question that I saw. About the use of use of adrenaline in the patient with normal heart rate.
Yes, on the adrenaline cluster. Sorry, Doc. On the adrenaline questions, just cluster that with the why dilute, and also as someone was asking why not atropine in neonates. So if you can just cluster that in your response, thanks.
Okay.
Yeah.
So if you are resuscitating and there's good heart rate, it means you are doing something good. Heart rate, it means resuscitation, you are doing better. And when you have a good heart rate, there's no need to give any adrenaline. What you need to do that is to give oxygen. So just need to continue just begging. You just need to be administering oxygen. There's no need to beg. We do not really use atropine as part of resuscitation of the newborn. Even on the drug list, we also didn't include it there because there is no room for adrenaline. It's not recommended. I haven't seen a study where they were using the adrenaline as a resuscitation drug for a newborn. The drug that we sometimes use in the newborn is naloxone, which is also not routinely used. So there was a question also asking about naloxone. For those who have received pyridine, is only used for only those who are not having a respiratory effort after birth. But if they are, the man may have got a pyridine, but the baby is having good respiratory effort, then there's no need to also use a routine naloxone.
Yes. And then on the drugs, someone asked about the sildenafil, says one of yes. Can you say more about that drug?
Yes, I've seen. Also the sildenafil is not a resuscitation drug. So sildenafil, we use sildenafil when we are treating for persistent pulmonary hypertension of a newborn, PPHN. So, and you, as a treatment, you don't start by symptom, you start by giving the basic care. You make sure you are giving adequate fluid, good oxygenation. Then, if the patient maybe show the sign of PPHN, that's when the sildenafil is indicated. I don't know if sildenafil as a part to be used during the resuscitation.
All right. Yeah, I think that is quite clear. Vuyokazi November was saying maybe we should not forget that in the room there's also an anesthetist. Most of the time they are quite, skilled in some of the research processes. And she was saying maybe the young doctors like myself should consider also calling, so what is the role of the anesthetist in this particular regard? Yeah.
Yes, for the anesthetist, yeah, it is deep, but sometimes they can assist. But but there are places where you may not have a pediatrician with you. And then in case of a resuscitation, now you have to go to the advanced. Then they can be very helpful. They can help you. It can also help you with the intubation. They're also very much experienced with resuscitation. With the intubation, they can also assist you when you have to go to advanced resuscitation. Most hospitals, like in the periphery, you won't have a pediatrician in the delivery room or in theater. You usually can find maybe just a midwives only dealing with the baby. That's where the anesthesia doctor become more helpful there to assist in the resuscitation. But where you have if you, like in the case you need hands, like they can be helpful, especially if the mother is stable enough. They don't need, or sometimes so difficult to be looking at a different side to get the mother and the baby if both are unstable. But sure. Yeah, but to be very helpful in case where you are there, we can be good to work with them in assisting.
Okay, Doc. No, thanks. And then there was a question about the umbilical cord to say, as part of the research, when to clamp or not to clamp. Someone was also asking, can we give adrenaline through the cord? What's your take on this? Thanks.
Yes. So the issue of a cord clamping, I think there's been a lot of study around that. It is it does help because there are a lot of benefit that you can get from that. You put more red blood into the red blood cell into the baby, which prevent the anemia, and also tend to prevent some complication like NEC, intraventricular hemorrhage. It does have a lot of benefit, which we recommend at least delay cord clamping, especially in the event where the baby is stable. But in the event where the resuscitation is needed, there is no need to delay cord clamping. You need to be resuscitated. That's why in that case, you have to immediately cut and then get the baby resuscitated. But if those who are calm, they are more stable, then you can delay to a minute to 3 minutes to cut if it's fine. Okay. So it's important. There are a lot of benefit from that.
Superb, Doc. There's still a number of questions. I think we can go for another 5 minutes and then we see, maybe for you to take a break. I see Alfredo Del Cueto. Would you like to make a comment or a question? Your hand is up, Alfredo. Alfredo, you may unmute if you want to make a comment or ask a question. All right, I think Alfredo maybe not really on this particular part. So there was I think this most of the initial questions, Doc, we have dealt with. The two more questions I want us to deal with is there a clear difference between HIE and birth asphyxia? I think this is from Aslem. is asking, can someone make it simple? What would be the difference between the two?
Yeah. So, yeah, the base asphyxia there and the HIE, there are criteria that we use to come to that. Because we don't just say base asphyxia by just looking on this baby's not crying or just have a low Apgas. You have to look at the criteria. So you can look at those Apgas. We look at the blood gas that is done after birth, or can be primarily called blood gas, or the blood gas that are done within 1 hour after birth. And we also do scan, they do MRI of the brain to check any damage. You can give a proper diagnosis of if there's really an HIE. So there's a lot. It's not a simple diagnosis. There's things that need to be done to do it. I think this asphyxia is a topic on its own. It's a full topic on its own, which I'm hoping maybe to be one of the follow-up topic when you can go details of that, giving all those criteria, differentiating the two, because others you end up being confusing most people, but they look the same and they are not, because we have to reserve saying I'm dealing with a base asphyxia or HIE because it also have some litigation implications. So we use those carefully, because you say something should have met certain criteria.
Great. Hlengiwe, would you like to ask your question? You may unmute, Hlengiwe.
Yeah, I hope my computer is dying. We are at when I load shedding where I am. So I think 8%. I hope it will allow me to finish here.
All right, colleagues. Yes, we have to sum it up.
Thank you very much. I've heard it all. Thank you.
Oh, you have heard it all. Thank you. All right, we are happy to hear that. So, Doc, as we close, what would be some of the key things that would lead to a failed resuscitation? What are some of the key salient things to look for?
Come again with the question.
Some of the contributory factors to a failed resuscitation.
Yeah, the first thing that I think I mentioned, the lack of anticipation.
Yes.
And the lack of preparation for your the team and the resuscitation equipment, and also lack of trained person to do adequate resuscitation.